this is a long question, but important from the ALK data of the final overall survival is that we do have the ability to prolong the survival of the patient with ALK-positive lung cancer. Now, ALEX is a study that was started over 10 years ago, comparing to Alectinib with the crizotinib, and we have demonstrated a significant difference in the progression-free survival of actually 34 months versus about 11 months. But now, for the first time, that we're able to record the overall survival at the median of 81.1 months versus about 57 months. Although there's no statistical significance, but the fact that the median 81 months is the longest we have ever recorded in patients with advanced non-small cell lung cancer. And also at 7 years, about 48% versus 30% of patients are still alive. And that's a very important message for our patient with ALK-positive lung cancer. So this is a complex question because there is the availability of multiple second-generation TKI and the third-generation TKI Alectinib. So right now we have the overall survival benefit, and then which will benefit the patient, but this is non-comparative with the availability of the third-generation TKI. So I think that there are external factors apart from the clinical trial that one have to take a decision-making. For example, patients with brain metastasis, the third generation may potentially give a better control with a long duration of intracranial response. So I don't think we can use our ALEX data over survival to help you to decide which is the optimal TKI for ALK-positive lung cancer. So for ALK-positive patient, I don't think combination strategy is a good idea. Number one, whatever combination is going to add on to the toxicity. So right now with such a long progression-free survival with the second and third generation TKI, I think single agent is probably the best way to go. But then there's a couple areas of significant interest is that at the time of resistance, what are we going to do? Now we have the fourth generation drug that is targeting the G1202R and other so-called the tough resistant mechanism. So that probably will be integrated eventually with so-called this group of patients. But then there are also other so-called resistant mechanism that's not ALK dependent. So more than 50% of the resistance are not related to ALK. So how do you tackle that? So what was the role of so-called ADC in this kind of situation? What is the role of a cancer vaccine against ALK in this kind of situation? I think those remain to be investigated.